induction course on success lies in Broca's area. Just before that, we have a very pleasant task. We have a guest talk by none other than Dr. Arun Sethi about the ambulatory surgical centers, standalone versus corporate versus non-profit, which will be for 10 minutes. So I request Dr. Arun Sethi to kindly deliver his guest talk.
Thank you very much. Can you load my talk, please? It's already loaded, I think. How do we start? Yeah. Yeah. So the talk that was given to me was to compare ambulatory surgical centers. So I wanted to tell you that basically what is an ambulatory surgical center? Okay. Just 1 minute. There's some. Now it's okay. So comparison of ambulatory surgical center ownership models, standalone versus corporate versus non-profit. Now, if you take an overview of the ambulatory surgical centers that are there, now these are the ownership models mostly based out of US, then I'll show you the international also. Now, why do people go in for an ambulatory surgical center? It's more cost effective, it's easier to manage your surgical list, you do not have to wait for turns because I work out of a multi-specialty hospital as well as an eye institute. So in a multi-specialty hospital, you are stuck with many times between two cataracts, you have to come out because they need the theatre for a road traffic accident. Infection rates go higher because right before you somebody's done a kidney transplant. Because most of these hospitals do not invest in a separate eye theatre because they say the returns are very poor. Secondly, in ambulatory surgical center, you find that the staff is dedicated and knows exactly what you want in terms of your anesthesia, in terms of instruments for surgery. So it has a lot of advantages and cuts down the cost. Now, there are three types of them. One is standalone, which is physician-owned. Second is corporate-owned, like we have the chains now in India also. And the third is the non-profit, which is on the side of those who run it like a trust. So, definition of an ambulatory surgical center is an outpatient facility specializing in same-day surgical procedures. So, patients should not stay overnight. Now, what is the role in healthcare? They provide efficient, cost-effective surgeries. They reduce hospital burden by handling routine procedures. They offer faster recovery and personalized patient care, and they integrate advanced technology for precision treatments. They also enhance accessibility, affordability, and quality. That's a fact. You know that 7 years ago, American ophthalmologists were getting around $2,800 per cataract surgery for ECC or PCIOL. As they kept saying that they're doing 3-minute, 5-minute cataracts, now it is down to $650. The equipment cost has gone up, but the reimbursement costs have come down. So now they've actually started issuing instructions that you cannot tell a patient or give any advertisement claiming that you do under 5-minute cataracts because the insurance company says now we'll pay you according to the time of surgery. So they're saying that please don't make it cheap, like abdominal surgeons don't say half an hour hernia or 2 hours of gastrostomy and all that. Now standalone physician centers, you have the full autonomy. Now if supposing I own the center, which I do in Gurgaon with my wife, then we decide the schedule, we decide when the surgeries have to take place, who's going to be our OT assistant, and so on. It increases the efficiency, it becomes cost effective, because sometimes we multitask the staff, and we are very quality focused, which you cannot do if there are multiple surgeries happening in the same. Now, the pros are, as I said, autonomy, and of course the financial incentives. You make your profit from the surgical fee, you also get some profit from the ambulatory surgical center expenses. However, everything is not positive. First thing is your management responsibilities. Physicians handle all the administrative tasks here. Even though you may have an employee called a CEO, you still are the final person to make the answer. Second thing is financial risk. You are building a financial center, say in Bombay or Delhi, it's a big investment and you have to be sure that you can recover it. Now, corporate-owned ASCs. These are managed by healthcare corporations. As you know, there are many in America and there are few in India. The first one was from the south of India, which went into liquidation. Then there is the advantage they have is scalability. So if they have 150, 200 centers, so when they buy a operating microscope, they'll order 40 pieces together. they're bound to get a better rate and better terms than what one person buying one piece is. Second is operational efficiency. So they'll have the same method of operation across the board. Third is financial stability. So if one center is losing money, hopefully the other center is making money, and you can write off the expenses from that. The challenges are there's less physician autonomy because now you're directed by shareholders, profit-driven decisions. So they'll say, if a patient has got a pressure of 22 with cataract, why not you put an eye stent along with phaco? Third would be the offers advanced care, financial security, and operational efficiency, but with reduced physician control. Now, corporate-owned also have their pros, operational expertise. Corporations bring in managing ASCs, leading to streamlined operations, reduced administrative burden on the physicians. The contraindications are limited physician control and profit distribution because now you're sharing it with others also. In the case of non-profit, it's a mission-driven thing. So the classic examples are your Shankar Netralaya, the Arvind, and these kind of hospitals, which focus on community healthcare over profits officially, and hospital and institution affiliations. They're often linked to universities or healthcare systems in America, like the Wills Eye Hospital and so on. Third is the high quality care. They prioritize patient outcomes over revenue. So you'll find that poor patients also get quality surgery. Now the challenges here are that you have to have good funding. You have to be slower decision making because they won't rush into buying an excimer just because somebody's saying refractive surgery should be done. They'll make sure that it really is viable and the community can afford it. It also ensures equitable, high-quality eye care with the patient-first approach, which is the ideal approach when we train as doctors. So now there's a comparative analysis as we've gone through it. So what are the control factors? One is control. In one case, you have full physician autonomy, and in one you have corporate-driven, in the third you don't. Financial implications, as you can see, there's higher investment in standalone, shared investment in corporate, and grants and donations for non-profit. Management responsibilities, again, are independent over here, but shared in corporate with the experts, and non-profit, of course, will be having its own team. The community impact is the important part. The focus here is on patient satisfaction and efficiency in a private ASC. In a corporate one is profit-driven. They have a weekly meeting. How many procedures each surgeon is doing, how much profit is he bringing, should he be kept or asked to go. And the third is the non-profit prioritizes accessibility and affordability, and everything else follows that like in the LVP model. Now, these are the case studies of standalone, corporate-owned, and non-profits. I won't go into them. I've already talked about quite a few of them. So there are a lot of these. I was actually the path breaking after orthopedics to invent the concept of ambulatory surgical centers. Then case studies in India. So one is ours. The other is Dr. Agarwal's Eye Hospital. Then you have the Arvind Eye Care System. Then considerations for choosing. Now it depends. What is your financial goal? Are you profit-driven? Do you want to be the controller and decision maker yourself? Or can you take the risks that go with it? Are you looking at growth and expansion or just one single ASC? And what are your community objectives? Are you interested in doing community work, making it accessible and affordable, or would you like to treat the elite and make your profits? So in conclusion, though there are different models, each has its own strengths. Standalone offers control, corporate ensures scalability, and non-profit prioritizes accessibility. And as I've explained before, that the important thing here is their financials are the important thing, followed by operational and community impact. And last but not the least, is alignment is the key. The best model depends on your financial goals, your risk tolerance, and your commitment to patient care. Choosing the right model should align with stakeholders' objectives and community needs for long-term success. Thank you very much. If there are any questions, I can take them if there's time.
Very well, I think, covered, sir. I think very comprehensive view of the different models available for an ambulatory surgical service. Thank you very much, Dr. Sethi. You can probably take your seat here. So we'll start with our instruction course. It's basically the pearls for a very effective ophthalmic practice. So I've titled it as Success Lies in Broca's Area. So we have a very eminent faculty lined up for this particular very important session. See, we do our practice We use our brain, we use our sensory cortex for seeing things and listening to the patient. We use a motor cortex for a surgery and for doing procedures. But a very important, also prefrontal cortex for all the empathy and the soft skills. But the very important thing is the Broca's area, where the way you communicate, the way you talk, when you talk right and when you don't talk wrong, things go very well. And it's a very important thing, especially for the beginners, that how well you speak to the patient, how well you communicate certain situations, how you break the bad news, how you actually explain the prognosis, and how to avoid some of the goof-ups that can land you in trouble. So this has been a very successfully run course for many, many years, being repeated quite often. So Dr. Kirti Singh will be speaking on how this whole thing starts, how to trace the roots of a bad communication. And I'll be speaking on the cataract surgery situations. Dr. Madhav Ambekar will be speaking on how to break the bad news in our routine practice. And we have none other than Dr. Quresh Muscati, who will probably add a lot of glamour to this by talking about the wit and humor in day-to-day practice. And Dr. Deepthi Joshi will be speaking on some of the communication pearls for postgraduate students. Dr. Satyamurthy will be speaking about the problems of communication in the refractive surgery practice. And the routine OPD goof-ups and how to avoid them will be spoken by Dr. Ravindranath. So we start with humor. That's probably the best way to start anything. So I call upon Dr. Quresh Muscati sir to speak about the role of wit and humor in the routine ophthalmic practice. Can we can you put this? I think this is on. Sir, it's here.
It's here? Your side?
Both sides. Okay.
I'd like to tell you that the humor also has limitations. As you can see, that the Chief Minister of Maharashtra is not very happy with one of the comedians.
Good point you raised, Arun. Please don't be a comedian in your practice. Use of humor and being a comedian are two totally different things. All those of you who are married have already developed a sense of humor because you've been suffering and you need some way out. So you're better at it than those who are unmarried starting practice. But a sense of humor and wit in our clinical communication is important, and it's unfortunately not taught in textbooks. So why is it necessary to have a sense of humor and speaking skills? See, patients come to you after you've, especially for those who develop white hair early, because they come for a second opinion many a times. Nowadays, patients are doctor shopping, so Google is opinion 1, doctor 1 is opinion 2, they come to you for a third opinion. So many patients have been frightened by another eye surgeon. He's told them, you've got a macular hole, and I don't know whether it'll close, it's quite big, we can try, but then you never know, you might lose whatever vision you have, you'll be blind. So all these things have been told, now they've come to you for an opinion. Or they've come to you first time and you're seeing a macular hole and you have to tell them something like this. But you have to couch it in a way that the patient will not get frightened and walk off before you finish telling them everything. So you need to put the patient at ease, then they'll be more receptive to what you're saying. Important thing for youngsters who are starting practice is that your speaking abilities will set you apart from your competitor in initial stage of practice. I experienced this. I had a very fierce competitor who shared the same waiting room and clinic, one Dr. B.T. Muscati. And we shared the secretary also. So the secretary would tell the patient that, what have you come for? She had been with him 40 years, and she asked, what have you come for? And if he said, for glasses, I'm 40 years of age, go to junior Dr. Muscati, because he will spend half an hour with you checking your number and giving you the correct glasses. Senior Dr. Muscati will spend not more than 3-4 minutes. His fees are double. And the important thing, if you're not satisfied with junior Dr. Muscati, you get a free consultation with senior doctor. So all these tips and tricks she used, because I had all the time in the world. I had one patient in an OPD, sometimes if I was lucky, 2 patients in an OPD. So I had all the time in the world to chat with the patient, to refract him, re-refract him, put drops and refract, call him again a second time for post-mydriatic test. All these things I could do because I had no patients at that time. So that is a time when you can actually capture the patients, see how patient you are with them. Explain to them with examples they can understand. So the important thing is you have to go to the IQ level of the patient and explain. It's all very well to have computers and laptop by which you show them things, but they get frightened of seeing a picture of an eye. They have not seen it. So I tell them that the eye is like a camera. The retina is like the film in the back of the old film cameras, and if it's a youngster, I tell him you won't understand, but if he's come with his father, I tell him you understand, no, old film cameras, our time. So then they follow. So the retina is like the film at the back, and the lens is like the lens of the old film cameras. So I explain to that first. Yes, I have models, I have color atlases, everything, but I first give them a little bit of imagery, and we get into laughter about old times and things like that. Humor should be subtle. Don't ever tell patients jokes. Just because you have the time, you can't tell them, have you heard this one or have you heard that one? That is, they think you're wasting time. So let's take a few practical scenarios. Doctor, is my cataract ready for surgery? So I tell them, I'm not too sure, is your pocket ready to spend? So then it immediately, I'm already talking to them about commercials. Is your pocket ready to spend? So then they start smiling. I tell them, look, whenever you are ready, whenever you feel that your vision is such that it hampers your lifestyle, then we'll operate. Then I give them an example. I said, you know, if you were Mukesh Ambani and you had to sign a $1 million check every day, and if the signature differed a little, government would fall. I would operate it today evening. But if you were Mukesh Ambani's mother who has to see only the large print of the Bhagavad Gita and is not interested in TV, I think we could wait for 5 years with the type of cataract you have. So I have explained to them, I have not told them anything wrong. I have told them that yes, if you want, you can do it tomorrow. But if you want to wait, we can wait. Ball is in your court. You'll be doing my surgery by laser, no? Everyone has heard laser. Even before femto came in, people were talking about phaco as laser. So I tell them that I'll be doing the surgery by what people call laser, by what most people call laser. So again, I'm covering myself. I'm not doing femto. I'm telling them that we're doing a surgery, which most people, because most people who are doing phaco are calling it laser. Which IOL is the best? So I don't have many people have a huge menu card of IOLs, right from rigid PMMA Indian, rigid PMMA foreign, and so on. So I've got 9, 10 different varieties. By the time I go to EDOF, trifocals. So I tell them there are only 2 types of IOLs. One is monofocal, where we try and correct you for a particular distance. One is multifocal, where we try and correct you for multiple distances. And the others are all first cousins and second cousins on the mother's side and on the father's side. So you leave it to me. We discuss only whether he wants monofocal or multifocal. And then he says, which of the multifocals is best, doctor? I've heard of Alcon, I've heard of J&J. So I tell them, see, when you go to a restaurant, you ask for kali dal, because you know that kali dal is very nice, you like it, you don't like yellow dal. Irrespective of the price, you choose kali dal, because you are the expert. The waiter doesn't tell you have kali dal. But when you come to me and I'm telling you, you've decided on multifocal, you leave it to me. I have discussed with you, I've talked about your lifestyle, what you need it for. I will put the best lens that I feel is possible, because here I am the expert. If I tell you that this costs 100 rupees and this costs 150, you will say, doctor, put the best one. So I will put the best one. So we never, 95% of my patients have no idea which company IOL I'm going to put, or whether it's a trifocal or an EDOF or whatever it is. I have discussed with them their needs, and I say, this will suit you. So there is a way of putting things to the patient such that you're not telling them lies, but at the same time you're protecting yourself. You're not showing yourself inferior to somebody else. I never use topical anesthesia. I'm one of those old school. I do peribulba for everybody. Now they've heard of topical anesthesia. They go around, they say, doctor, you'll be using only drops, no? If you're using it, you say, yes, I'll use only drops. But here I'm not using drops. But I'm not inferior to somebody else. So what do I tell them? I said, if you want, we'll do it under drops anesthesia. Don't blame me if I shout at you for not looking where you're supposed to look, if I scream at you during the procedure, and if something goes wrong, if I blame you because now I have somebody else to blame, you moved. No, doctor, you do whatever you think best. So, okay, you leave it to me. So, this is the way you don't show yourself inferior, but use a little bit of humor in your practice. You guarantee I will not need glasses after surgery. No, I don't guarantee you any such thing. Do I guarantee you that when you walk out from my clinic, you will not die of a heart attack on the 5th step of I'm on the 1st floor, on the 5th step of my staircase? No. So nobody guarantees anything. Medicine is not playing with computers. I guarantee that I will try my best to see that your requirement of glasses is the least. But your eye may not behave the way my computer expects it to behave. Means putting the fault on him. It's not that my calculation error, but your eye did not behave the way I expected it to behave. And my computer has got an algorithm of 50,000 eyes. Still your eye did not behave that way it should have. So you will get a number. It's possible. In glaucoma, I find it difficult to remember my eye drops. Is it okay? Yeah, it's okay once in a while, but establish some system. If you have somebody else in the house, ask them to remind you, set an alarm. Will I go blind, doctor? So if the patient is got a risk, actual risk of going blind, you tell them, we will try our best to protect whatever you have. You already come very late to me. We'll try our best to see if we can keep you going as long as possible. You're not using the word blind, but you're putting it in a way that is more palatable for the patient. And can you restore vision in my left eye blind due to glaucoma? No, it's like the heart which is dead. You can't revive it. Similarly, your left eye is dead because of glaucomatous optic atrophy. Nobody in the world can revive it. Nowhere in the world can it be done. Even if you are Dunya ka Raja with crores of rupees, it cannot be revived. So that you tell him that he doesn't go doctor shopping. And similarly with retinoid or any other, I'm not sure what the timing structure is, but why is this surgery so urgent? So why is retinal detachment surgery urgent? Doctor, I've got my beti ki shadi, something like that. So I tell them, no, it's not urgent. It is only urgent if you want to have a reasonable chance of getting good eyesight. Otherwise, it is not urgent. You can come back to me after 6 months. It will be more difficult at that time to do it. We'll still attempt it. You'll still pay the same fees. But at the end of the day, instead of telling you 70% chance of success, I'll tell you 20%. So you convey it with a little bit of humor, but you drive home the points that you want to. How do I get rid of my floaters? I tell them, look, I am married. I get floaters. Sometimes you realize your wife is standing in front of you, your spouse is standing in front of you, and she's been talking for 5 minutes, but your mind is elsewhere. You have not noticed her. If you have not noticed a 5 feet 6 inch person in front of you, why are you keeping on noticing these microscopic floaters? Just ignore them as you have been trained to ignore your spouse. So little bit of humor there, telling them that something just like a spouse, you have to suffer them. You have to suffer the floaters. One fine day they will go away. I can't say the same about your spouse. So I invite you to ask me questions. Just pretend to be a patient. Ask me any question related to something which a patient has asked you. And let's see if we can give them an answer which is a little more palatable. This is some of the examples I gave you are just one way of managing. You can have another way of managing. There's no right or wrong here. And the important thing is not to get defensive or irritated, irrespective of the question. Yeah.
Very nice tip, sir. How you explain to a patient about the postiopolar cataract?
Sorry.
Actually,
yeah?
sir, we have overlasted the time. Okay, we can just take this quick question and we'll...
Yeah. What is the question?
How you will explain patient about the postiopolar cataract?
Yeah. So I tell them, it's important to tell them first. I tell them that, look, you've got a peculiar type of cataract, maybe because of the steroids you used or you were born with it or whatever the thing may be. But it's the capsule at the back. I tell them that it's like a shopping bag. And the shopping bag, the lining of the shopping bag is very worn out. And it can break on its own. It may be broken, which we don't know. But while I'm operating, it is possible that that thing can break. We will try and be very careful. We will use all safeguards. But I may not be able to put the lens that I'm planning to put. I may put a different type of lens in the eye. And there is a very, very rare chance that I might have to have a second surgery in case while I'm operating, the whole lens falls into the back of the eye. Nothing to be alarmed about. But after a few days, we'll get that out and then put an appropriate lens. Mostly everything will go off well. Don't worry about it. But this can happen. So you tell them, but don't scare them away. It should not be so scary that he will go to somebody else who will say, "Kuch nahi hone wala hai. Maine hazaro case aise kiye hai. All will be fine." That is wrong. So you stick as close to the truth as possible. Yeah.
Sir, I think time is up.
Thank
15
you.
minutes.
Thank you.
Okay. Can you take Dr. Krishna Prasad's talk? Yeah. So thank you so much, sir. I think we can go on and on with wit and humor, especially with Dr. Quresh. And it's always important that we use the it's not there? Dr. Krishna Prasad? Not there. Then I'll call upon Dr. Madhav Ambekar. He will be speaking on how to break the bad news. See, always, not every time is a hunky-dory situation. There will be sometimes we need to tell the hard facts. The patient can actually have that tinge of displeasure, or it may be really a bad, life-changing situation. So in such situation, what are your communication skills that you need to employ, and what the soft skill and the empathy that needs to kick in, so that you really do the treatment without, really the patient getting the harsh truth very blunt at him. So over to you, Dr. Ambekar.
Thank you, Dr. KP. We have been doing it for quite some time. And actually, this is something like bailing the cat. That any bad news is you have to bail the cat. Because I have slightly enhanced the subject, saying that effective communication is a part of breaking the bad news also. So why the communication is important? That you need to understand that what is the patient's demand. He's illiterate in sense of the medical science. He may be a very educated person, but he's illiterate. And in the current context, they try to get the information from the Google, but that's an information, that's not a knowledge. So you have to give then chronicity of the nature is there, like ARMDs or glaucoma or any other disease which are chronic. And you have to have the patient satisfaction and the trust to enhance through the good communication, because that is enhancing the trust becomes the most important parameter where the patient has to understand why the patient has to trust you. So you have to be active listener. You cannot divert yourself from on a phone call or your colleagues or the staff or anywhere that you keep talking to them. So instead of that, you say that I am listening to you, and that is the most important parameter to have better success. And success in terms of good work, good repute, and you have to be a soft-spoken person. To project that you have empathize his disease. You are trying to treat his disease with empathy. And as it goes, that in every culture has got its own system. So calling them we are from Maharashtra, so we speak as kaka and uncle and so on. So senior lady, we call it as dadi or something of that kind. So proper communication is equally important. Most of the time what happens is that breaking the bad news becomes the most difficult task, that we have to bail the cat, because we have to manage the patient's expectation and their anxiety about the things which have happened, and balancing the empathy towards the patient as well as having the professional objective that without threatening the patient, but giving the proper the idea of what the disease and the outcome of the disease itself. So this is the Kalamazoo, which is in the Michigan state. So they have I have given this, that how it should go, that you should be in a calm room and then gather proper information. You should not keep collecting the information while talking to the patient, and try to solve the problem of that complication so that patient's relatives are happy. So during the first visit, you have to get proper connected with the patient. You have to have the perfect listening what patient is talking and what he wants to say about his disease. And always do not think in terms of chair time, that he has been sitting for more than 2 minutes, 3 minutes, and so on. So it is always better that you should have a proper listening. An ear has to be there, and counseling becomes the main crux of the story. So get yourself to reach to the root cause of the complaint. You are a primary eye surgeon. Patient would come to say that vision has become poor, but you cannot say that I am just a glaucoma surgeon, I am not a retina surgeon. You try to reach to the cause of the disease, and then even if you are not able to treat it, but properly you have to send the patient at a place appropriately where the patient has to go. that keeps sending patients to Kurish also for some low vision aids situations. And because of which, once you have understood that this is the patient, will get a confidence. So even if the patient is sent at a local level also here in at my place, I have never lost a single case in last so many years of time. We have to read the body language, what patient has to communicate. During the follow-up also, we try to remember the patient, have a recognition smile and so on. So this is not the part of the breaking the bad news variety. Now it comes as a technical and the commercial counseling also, because patient doesn't understand the technical intricacies of what you are trying to communicate. So you have to give the appropriate and reasonable examples from his line. And then as correctly Kurish has said, my common example is if a lady is there, we say that somebody is asking you to make something, and it is always there that you prepare, but then the fellow will say that there are 5 people for dinner or lunch. He will never say that use this much of the salt and this much of the other details into the whatever vegetable you are making it. So effectively, without putting the technical intricacies of the medical terms, you try to explain them in their own language. Give them the bird's eye view and make them aware about the procedure and what are the chances. Because I keep coming across patients, those who have been given the anti-VEGFs for literally the n number of times. Patient has paid more than 3 and 4 lakh rupees, and patient has never been counseled that what are the possibilities of vision to remain constant or the improvement. So we need to have, as I said, we don't threaten the patient. As I gave you the example that ARMD patients are most unhappy, so whatever number of injections you are trying to give them, that you have to give a proper idea. It's like an orthopedic surgeon, you know. Orthopedic fellow will keep saying कि इसको अभी ये plaster 4 हफ्ते रखते हैं. 4 weeks down the line, he would say, नहीं, थोड़ा सा भी बाकी है, then we'll keep it for 2 more weeks and so on. So we have to be giving him a proper idea that what is the end result and what will be the end point, both. Unrealistic outcome is very important, that as Kurish has correctly said, that chashma hi nahi lagega wali baat hi nahi. The spectacle dependence will become less. You will not have a spectacle-free vision. And patient always has that more amount is paid, that there are huge expectations. And I always say that I am in the healing ministry. Charges is the billing ministry. So I don't look after the charges. So somebody else would go into the billing ministry, that you talk to the billing ministry, while I'll give you the idea about the healing ministry only. So counselor will give an idea. Now, what is the bad news? Any information that is negatively implying, let it be anything, like a nucleus drop, not putting the IOL, or advanced glaucoma, anti-VEGF related, the ARMDs and so on. So effective, you have to give what are all these bad news are there, and effectively requires the empathy, clarity of vision, and making the patient prepared to accept that bad news. Like it can be a choroidal melanoma also, which is very uncommon in our area, but I have seen almost 3-4 cases in my entire career. So medical errors and surgical complications is also a major bad news, which KP is going to tell about. So this is the protocol, that setting up a proper place, then giving a prescription, ask the patient what he would like to know about, give him a knowledge with a emotional respect about the patient, and summarize everything so that you can close down on the case. Giving the baseline idea of any table issue, that again KP would tell us, but then you have to give the realistic what has happened without giving the lot of medical clutter to him, and for which your own calmness is the most important parameter which is there, and maintain absolutely subtle voice so that patient will never feel that you are under anxiety and stress. Immediately, it is always better to tell the patient that lens has been put in, or that some different variety of the lens has been put in immediately post-op. So without giving into the medical, too much of the medical terminologies, and give accurate information which is masked, but actual information, and about their concerns that if posterior pelvic cataract, the nucleus has dropped, tell them that this has happened, and then you have to go to the VR surgeon, which anyway we have counseled at the beginning itself only. And you have to be assertive but meaningful. As it goes that net gurus are always there, that Google doctors are there, so you have to make them understand that what you get on the net is the information. It is not your knowledge. You have to apply wisdom to put that information into knowledge. Because I give a most common example is that looking into the YouTube, somebody in the US started making some Indian dish, and then he called after, "Mummy, wo आधा घंटा हो गया, dish तैयार नहीं हुआ है." Then suddenly mom realizes that on the video that he has not put on the gas, because YouTube has not asked them to put the gas on. So the gas was not on. So it was like a Virbal's khichdi that he was putting the utensil on the gas without putting on the gas. So it is something of that kind, that information and knowledge are different. And any such things, you have to keep your anger under control because you are into the service industry and have a proper communication. So unless you get into the proper communication, the bad news has to be properly put to the patient. That is most important. Thanks, KP. Anything, normally if anybody has a problem, they can ask me also that how you present certain bad news also, as he has asked about the posterior polar cataract.
The bad news is you only have 10 minutes, sir. This we could have gone on and on. Thank you so much, Dr. Madhav Ambekar. We have Dr. H.M. Ravindranath now, who will be speaking on the day-to-day problems of the OPD communication. See, we normally, patients first come to OPD and then see us, then they decide whether they should come into the OT or not. So OPD is something where most communication happens, and that is where we can actually goof it up, and we can also actually win brownie points. So that's where the Broca's area is most active. So we have none other than Dr. H.M. Ravindranath, who is a practitioner in Davangere, Karnataka, who has been very successful with his Broca's area. So over to him.
Thank you, KP, for keeping me in the squad, even after inconsistent performances. This topic is very close to my heart because this is the one thing which I have not learned by reading books. This is totally experience for the past 25 years, and intelligence can be artificial, but stupidity is always natural. So this all things have I have learned with my stupidity. The situations are many situations when you communicate with it could be with the patient or attendant or staff of the hospital, colleagues. Sometimes VIPs. There are two types of VIPs. One are real VIPs. Second, the people who think they are VIPs. The second type of people are very difficult to manage. And some people come with colorful visiting cards and claim that they are head of secretary of some organizations. Those are the difficult people to convince and communicate. And government officers. Many a times these officers come with a title. You know, when they come, they don't come not only as patients, they come as commissioner, they come as police officer. So they think they are officers even in our offices. And some special situations where you have to break the bad news and talk to the mob. And you are head of the hospital, and you are responsible for the communication of your staff, counselors, nurses, other doctors, case sheets, consent forms, instructions, and handouts on displays. So basically you have to take in charge of all these because you are responsible for this. So communication can be verbal, writing, signs, or even act, body language, attitude, and tone. So all these constitute the communication. So any communication mishaps, because of these things you are responsible, and you should change. So the areas in the hospital where you can have these interactions is reception, waiting hall, consultation rooms, procedure rooms, inpatients, OT, and post-op events. So as my talk is with respect to OPD, I'll just say, first, when your patient comes, he'll go to registration. The two important areas, important things where at the time of registration, miscommunication can happen. That is, one is waiting time. See, many of the times, our reception will tell, wait for a few minutes and wait for some time. The some time and few minutes are subjective. Few minutes can be 5 minutes for you, for the patient, it can be 2 minutes or 30 minutes. So you have to be very specific and instruct the reception area that what is the approximate expectation of waiting time. It could be half an hour, give a range, 30 to 45 minutes, 1 to 2 hours, and it will solve most of the problem. If you say, wait for some time, wait for a few minutes, things are not done. So this is one area where communication gap can be there. Second is triage. See, you have to triage the patients because some patient with diabetic retinopathy needs dilatation, OCT, scans, maybe lasers. They may need even 2 hours, 3 hours. But if a patient comes with a conjunctivitis or external hordeolum, it takes only 2 to 3 minutes. So basically in waiting area, the reception should bifurcate the patients who need immediate and early treatment, and you can be disposed of. So this is important in registration area. Second is in waiting hall. Some area we have similar names. Like in our area in Karnataka, Basavaraj is very common because Basavanna was born in Karnataka. So in Andhra, if you go Reddy, in Tamil Nadu, if you go Murugan, Senthil. So common names are very difficult. If you have 2-3 patients of similar name, then you may mistake the one patient to the other name. So what we should do is, usually what I do, what I have learned over mistakes is, we usually add the name of the place, like name and name of the place. So then it will solve most of the problems. And sometimes putting a dilating drops in other patient or attendant sometimes, because they are sitting together, both are giving the same face. So what we do is, whenever we put a dilating drop, identify the patient and give a cotton swab or a wipe, so that you can identify which patient you are putting the drops. And this is one of the areas where communication goof-ups can happen, is assumption. Majority of the times we Indians, we think if you go personal, the patient will be very happy. So if a patient of 30-year-old male come with a 25-year-old female, they come, sometimes we assume that they are husband and wife. So I have faced a lot of problem with this. So once one patient came, she had come with a headache. Then I thought they will be very happy with my joke. I told, this person is responsible for a headache, your husband. Actually, he was her neighbor. So that is you should never assume what is the relation between those who have come. So this is very important, because we Indians, we think that because I am married, because our generation we used to marry 3 to 5 years younger. So nowadays it is different. So we always think in that line. And assuming patients know the procedure. Now we know cornea is front, lens is behind, retina is behind, because we have read anatomy and physiology, pathology. Many a times we think that patient also knows what we know. Actually, for patient, retina is somewhere, cornea is somewhere, lens is somewhere. They don't understand the 3D concept at all. So thinking that patient knows, we explain the procedure. So this is one thing. So assuming that staff knows this. Some basics, when the patient comes inside, so patient has bought your time, so you have to be completely responsible and give 100% to your patient. Looking at the WhatsApp, answering the friends' calls, definitely they are not done when you are in with patients. So don't interrupt, let the patient tell his own story. If the communication is good, it is said 90% is listening and 10% is speaking. And no negative remarks on professional colleagues, it's understood. And stress the importance of follow-up, especially diabetic retinopathy and glaucoma. That's why I write, and we always have a reminder call for these patients. Even if you write, come after 6 months, they will come only after vitreous hemorrhage. This is very common with diabetic retinopathy patients. And one of the areas where is counseling room problems. Like, see this clarity on charges. Once, just last week only, one patient told her, I told to put 40,000 rupees lens, you have charged total 40,000 rupees. The lens is only 20,000. So patient should know the split charges, what is the package charge, whether inclusions and exclusions. So you have to be very clear, that counselor should be very clear on the package charges. And 2-3 years back, one patient, I told you need both eye surgery. Then he came for the other eye surgery next day. Then he was very happy getting the surgery done. And next day when our receptionist asked told yesterday I paid for the both eyes. He thought the money was for both eyes. So you have to be very clear, the charges are for single eye. And very common problem is near vision problem after cataract surgery. If you don't counsel them that there will be a near vision problem after monofocal lenses, once around 4 or 5 years back I had operated on a patient. He was one-eyed. His name was Subhash Chandra Bose. Next day when I came, he was sitting like this. Then what happened, sir, I was reading earlier, now you have removed all my near vision. So you have removed my vision. So this is the problem. So unless you explain the near vision problem after monofocal lens surgery. And free from glasses or less dependency in glasses. This is also to be told. and flashy statements like throw away glasses should be avoided. Always over deliver and under promise. And misinterpretations, many people think cataract surgery, phaco and laser are same, so you have to tell them. And Indian and imported lenses, better to avoid these words, but better to tell premium lenses, regular lenses, or type of lenses rather than using Indian and imported. Especially after this Make in India and Vishwaguru concepts, many people are offended if you say Indian lenses are less this thing than imported lenses. And laser is answer for all the ailment. Many people think like that. Avoid over sophistication. Use simple words. Think patient is a layman, and use in a very simple language instead of using vision, 6/6, contrast, color, all those multifocal, glare, halos. Better to be in a very simple language to tell the layman. And it's very difficult to tackle these Google graduates. Tackle them in their own way. And too much weightage on IOL should be avoided. Take your responsibility and take your surgical skill into confidence. The take-home message is you have to prioritize the problem and who needs what, and tackle the complaint and treat the patient as a whole, not just the complaint. Thank you.
Good timing, sir.
Can we have Dr. Krishna Prasad's slides? Thank you so much, Dr. Ravindranath. I think the patient has come to the OPD and is agreed for cataract surgery. Now he comes into the cataract surgery situation. So I'm just going to share some of the things that I do in my practice. So cataract surgery, what are the communication problems in cataract surgery? So basically, it's a forgotten soft skill. We don't normally teach our postgraduate. There's no curriculum in medical school or in post-graduation about how you communicate. Basically, you just learn by looking into our mentors. So it actually adds value to your surgical outcome. You can actually soften the blow. You can probably get brownie points if you are a good communicator. So the first thing is the second eye syndrome. See, let me just tell you a situation which normally I face. When the patient comes with both eyes cataract, I do a surgery, topical phaco, surgery goes very well. Patient is very happy after surgery, thinks I'm God, he's able to see everything, and he says, sir, I want the second eye surgery. When he comes for the second eye surgery, undergoes the second eye surgery, which is absolutely uneventful, just like the first eye, he's not at all happy after the second eye. He says, sir, the second eye surgery took too long a time compared to first eye. I could see very well after my first eye with the first operated eye, but the second eye I am not able to see anything. Okay. And he says that when you did the second eye, anything problem happened because I had a lot of pain and discomfort. So why this happens? See, there's a WhatsApp message which says all problems in this world are because of two things. The two evils of life is one is comparing, other is expecting. If you don't compare yourself with anyone else, you will be always happy. If you don't expect anything from anybody, don't expect anything from your children, spouse, teachers, students, you will be very happy. Both the evils work on the second eye. When he comes for the first eye, he has no idea, he only has fear. He only has insecurity. He thinks that whether I will be able to tolerate this surgery on a very sensitive part of the eye. When he undergoes surgery, much to against his expectation, things happen very well, painless, short procedure, because he was expecting it to be a longer one. He is very happy. Now, second eye when he comes with expectations. He expects it to be very short procedure, painless, and he is going to see the moon, see everything. So with this burden of expectation, he thinks that even though you took the same amount of time, he thinks the surgery took longer. He thought it is very painless, but he had some discomfort. He always pits it against you. And very importantly, when he got the first eye operated, he compared that eye vision, even though it is not great, to the second eye which had cataract. Obviously, the first eye looked bright. Now when he gets operated for the second eye, he compares the second eye vision to the first eye which is already recovered and seeing very well. When he compares, he doesn't have the third eye with cataract now. So he says the second eye, I did not get good visual recovery. So this is about both expectations and comparisons spoiling the face. So I always tell the patient, second eye will take little longer. Second eye will be little more discomfort, you'll have little problem. And second eye will take more time to recover. Okay. If you can explain these evils, better. And about the, Dr. Ambedkar already, see, my bad news is like in cataract surgery that you have, okay, you dropped a nucleus, you can put an IOL or whatever happened. See, the best time, see, if you have, let's say, 20 cases lined up, second eye, you have, there's a drop nucleus. See, you don't want to break the rhythm. You say, send the patient to the room, I'll come back and talk to them later. You finish your list and go on, you want to spend a lot of time explaining the relatives. Never do that. See, our patients see a lot of movies, Bollywood movies. What is the typical Bollywood movie operation theater? There's a closed door, there's a red light blinking, and people are walking in front, back and forth, and suddenly the door opens. Surgery is over, the doctor comes out, sometimes without a mask, without a cap, sometimes wearing a stethoscope, and he delivers a judgment. The surgeon delivers a life-shattering judgment. He says, बच्चे को बचा सकते हैं, नहीं तो माँ को बचा सकते हैं, whatever. Or he says 24 hours, होश नहीं आए तो गया काम से, whatever. Some life-shattering, life-changing judgment is given soon in the OT itself. So our people are conditioned to hear the bad news in the OT premises. Okay, so that is your area. That is where they are vulnerable. That is where they are mentally tuned to hear the bad news, because things can go wrong in a surgery. That is what they are tuned to. So you go out to the semi-sterile area with a mask, gown, everything. So that's why you are hovering over them. They are actually overpowered by your presence. Then you say, we started operating, we found some problem there, and should not put the IOL now. I've asked my colleague, a vitreoretinal colleague, to come and help me. I think we'll set it right, don't worry. So they will take this news well. If you wait for your 20 cases to get over and go there, by then that vulnerability is gone. So they can turn hostile. They may probably, and also in the court of law, they may, if something happens, like they go to the court, you say, sir, doctor, he botched up my surgery and he didn't care. He came next day evening to meet me. What happened? He didn't even care. If there's a problem, he should have told me, right? That is that much of sense and compassion he should have. That may be pitted against you. Multifocal, see, very simple. For all juniors, it's very easy. Patients can get into trouble post-op. If you put a monofocal, there's a problem. If you put a trifocal, there's a problem. So let's use this, clarity versus convenience. Ask the patient, what do you want? You want clarity or you want convenience? If you want crystal clear vision, go for monofocals, but you have to have a small inconvenience of wearing glasses at times. Whereas he says, I want convenience, I don't want to wear glasses. Then you might have to forego a clarity a little bit. Don't overdo it. Okay. So if at all he says, why I'm wearing glasses? You chose clarity. He said, why I'm seeing rings and halos? You say, you chose convenience. So this is a very clear, oversimplistic, but a very useful way of trying to understand how the patient can see the outcomes of these surgeries. See, we always have to have counselors. You have to first counsel a bit, send them to the counselor, let them confuse them, you come back, you convince them. And FAQs, this is very important, like for toric lens. See, you always see patients to think that toric, you are jacking up the price. Always I tell the patients, you have two problems. There's a recent problem called cataract, and there's an old problem called you got a crooked cornea. If you want to solve both the problems, then you need to probably pay a different package. I can use a specialized, customized lens for you. If you want that old problem to remain there, you have to wear glasses. I can only solve the cataract problem. So telling that it is your astigmatism, your crooked cornea, probably will not make the patient think that you are overcharging them with some new package. And that is true also. That's the way it is actually. And don't market the IOL. Don't have different packages. If you are operating, this is your price. Ideally, we should have our charges, and only the IOL charges should change. We cannot just charge because it's an imported Indian or something else. Ideally, a time should come where if Dr. A is operating, this is the charge, Dr. B is operating, this is the charge. So that is like advocates who have different packages. And lastly, very important, endophthalmitis, life-shattering, demoralizing, very disaster in most people's cataract surgery life. So it both calls for art and science, very important. You know the science part of it, but the art is very important. Please accept it. It is not TAS. It is endophthalmitis unless proved otherwise. Please fall in line, be proactive. Don't sit on it, be judicious, very important. Patient thinks that you have botched up the surgery, you basically promised a lot of things, there's a breach of promise. Associated with loss of vision, he also has pain and discomfort. And he thinks you are no good. He says it on your face, doctor, I came with hearing about your fame. you are no good, you are useless, please take it. It's okay, please take it. How to handle? Take care of them immediately. Please sensitize your staff. If somebody comes, got operated recently, comes to have a sudden loss of vision, whatever it is, maybe corneal edema, even high FEMA, whatever. Once they say, I can't see well from today morning, they should be taken care immediately. You may have 100 patients waiting. Please tell them to immediately take them away, whisk them away, and see them immediately. Even if you take 10 minutes, 15 minutes to see them, they may say, I waited for half a day waiting for this doctor's attention, he didn't come. So make it look quick and make it private. Don't ask them in front of other patients. They may say that you operated, I'm not able to see. Okay, it creates unnecessary problems. Show concern, but you don't have to bend backwards. Don't panic. Okay, you don't have to show your defensive attitude. And please ask this is very important. I do a topical surgery, so patients normally cease immediately after surgery to some extent. Next day it gets better, and the bacteria gets into vitreous cavity, proliferate, exudation, vision drops on second, third day. This is your window of opportunity. Please ask them, if the vision is not clear soon after the surgery, then something my surgery might be wrong. I did the surgery, patient saw for 1.5 days, then the blurring started. Then the temporal sequence is important for the patient to understand. You have to make him understand. You ask him, when did the blurring start? Did you cough? Did you sneeze? Did you not put drops correctly? Somebody elbowed you? You rubbed the eye? Put some kida in his head, that when did this start? He will say, yeah, I think I cried, I rubbed, I didn't put drops. Some event would have happened so that patient connects that to that, and he starts becoming more defensive. Never use the word infection. Tell all your juniors, staff, your residents, never say, you can't say, what happened? So you got an infection. Infection means septic. Don't use the word septic, pus. No. Say it's reaction. Infection is also a reaction, inflammatory reaction. Keep it as, treat the reaction. Don't say infection. Don't despair. Don't agitate. Okay, and take the hostility head on. See, important, don't overreact. Natural course, patient denies it, becomes hostile, later falls in line. If you really show compassion, show your professional competency, everything is fine at the end of the day. Hold on to your nerves. In India, we don't have too many litigants, thanks. Medico-legal issues, you may be right. A lot of doctors win their cases in endophthalmitis cases, but please prevent it if possible with good communication. Anticipate, keep all the law is the slave of evidence, keep every record, keep it clean. Very important, hire a good advocate, document. Thank you very much for your kind attention. Now it's time to call Dr. Kirti Singh. Kirti Singh has been an exponent of, advocate of good communication for postgraduates and young ophthalmologists. She has a lot of key research in this developing soft skills and empathy and communication skills. So she's the right person to understand why at all we communicate wrongly, how to trace these roots of bad communication, where does it start altogether. Over to you, Dr. Kirti.
So thank you for having me a part of your team for the last 5 years. I have a question for you. Why do you always give me the bad things to talk about? Bad communication, because that's self-explanatory. Anyway, thank you. So Dr. Madhav and Dr. Ravindran have made my task much easier because they've covered some points. So what is the genesis? कुछ भी आग लगती है तो आग बुझाने से काम नहीं होता. You have to know why the fire was burning. So poor communication or improper transference of data, of idea, is the genesis of the mistrust between the doctor and the patient in the current era. And this because of a disconnect between heart, head and hand, the 3 H's. Therefore, it is more of conflict. And optimal communication with empathy, I'm a proponent of empathy, is a solution. And empathy is just not sympathy. It is just not that you're born with sympathy, you cry when the patient cries, or you feel sad when the patient is sad. It is that you go ahead and understand what the patient is feeling and try to rectify it. If you can't rectify it, if it is beyond your control, like endophthalmitis, you help the patient deal with the consequences. That's what empathy is. So the topic given to me by Dr. KP is roots of this thing. So first root is ignorance. And I would say, sorry to say, we are all doctors, we are the elite, we have a good IQ. We do not have that good an EQ. So arrogance and unwillingness to learn, and sometimes it is basically just fear of displaying ignorance. It will be both ways. And there's a very beautiful picture in which the cat thinks that she's the lion. I mean, she wants to be the lion, but she's not the lion. So you kind of think that you know everything, and that's the, in fact, fallacy of youth. When you become a little gray-haired, you realize you don't know many things. So that is the ignorance. You first of all, you have to accept that I accept I'm a bad communicator, and that's the root of my problem, and that's what you'll have to accept that. Second, this is my 1981 class. Literally, this was my teacher, who's still alive, and she was an anatomy teacher, and this is our anatomy lesson being taught to us. And look at the anatomy lessons now. So things have changed. There's a focus on technological skills, especially for ophthalmologists. We are dependent on machines a lot, and that's important. There's nothing wrong with that. But on the other hand, we should also have focus on the effective domain. And that's what the reason of, one of the reasons, roots of poor communication is this. And this death grip of technology has reduced the human interaction. And this is starting right from undergraduation to post-graduation, and I would say even before undergraduation. Third, something we always talk about in our medical education lectures is, unless you assess it, you don't learn it. If you don't have exams, your students will not learn. If we did not have exams, we would not have learned. So same way, unless you assess something, they're not going to learn that. And the cognitive and cognitive domain is assessed by all your MCQs and everything, and psychomotor by your viva and the practicals and the surgery, but the effective domain is never assessed. So that is the problem, that these communication skills have never been assessed, and knowledge and skills are more easier to assess. Time. Dr. KP has 20, 30 surgeries to do, and so do the other super surgeons sitting here. You have so many patients, 1,000 patients waiting for you. Where is the time to communicate? And there was a very beautiful study, for lack of time I'm not quoting the studies, that how much time does it take if you talk to the patient, and how much time does it take if you just tuck, 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 do a tick box exercises. The time limit wasn't very different. Then patient feels unimportant, therefore anger is just thwarted desire. If the patient feels ignored, and then the anger starts. And then doctor feels that anger, and that cycle starts. So for doctor-patient relationship, you have to have a little bit patient-centric. And therefore, when you see this, anybody can read this, is it me or is it you? It's both. It's me as well as you. Okay, so when the me becomes you and the you becomes me, when there's a trust, then your relationship is better. And that is why all this focus on ATCOM of the medical education, just change in undergraduate, I just hope it doesn't remain on paper, it is actually done and assessed. Modern communication, many of you sitting here are on your mobile phones. What is more important? Listening and, okay, I'm not that important, but when you are in the OPD, we rightly said, Dr. Ravindran, that if you are in the OPD and you are on the mobile phones, you are connecting with some distant person who's sitting, let's say, Calicut or Delhi or Jammu, and the person sitting right across you, not communicating with that person. So that's not right. And the next thing is modern communication. Like this was in 1858 about telegraph. That's sudden, superficial, unsifted, too fast for truth, trivial, paltry. And this was said around more than 100 years ago for telegraph. So for now, the instant WhatsApp and the instant Twitter, everything. So this is what I was talking about. This was the light sculpture which got the best prize in 2019. It's called as addiction. And based on this, there is a term in Oxford Dictionary now, phubbing, practice of ignoring one's companion or companions to pay attention to one's phone. And we are all addicted, guilty. This is a very beautiful movie if somebody has seen it. Audio, please. Can I have
भैया कभी-कभी दो बातें ना होते हुए भी हो जाती हैं.
So let's just start that.
आप लोग तो समझने की कोशिश ही नहीं करते ना. अरे भैया कभी-कभी दो बातें ना होते हुए भी हो जाती हैं.
So this is a very beautiful movie, but the why I'm talking about this aspect is that he masquerades as somebody else in this movie, and the non-verbal and the verbal languages were very important. The way he's communicating कि आप कहते हुए भी नहीं कह रहे हो. So it's not what you are speaking which is important. It is your voice, your body language, and your non-verbal language which is most important. And this body posture, your facial expressions, they are all depicted so beautifully in all the muses of India, and that's really important. So, and this picture tells you that communication has to be effective. So I may go to South India, or in South India I may come to North India, or West India to East India, or you may go to Japan or China. But if you can have a non-verbal communication, the barriers will go away, and visual communication is the most effective, as this picture who has lost the child has lost the mother and is just wanting to cuddle up, is telling you. And the same, another thing, the child just feels that this rabbit has fallen down and wants to be picked up. So the visual cues which you give to the patient, your smile or inappropriateness of smile is the one which is important. And we do know, this is a fact, like Dr. KP said, you have to accept that we are no longer a second god on earth. Our parents may have thought that, we don't. And this deteriorating doctor-patient relationship is causing violence, and we have to understand that only person we can change in our life is us and not the patients. So use that empathy, and that's what we do. We have to be good role models. And we have to, whatever we are today are because our teachers taught us, and what our students will be what we are teaching them. So let's mind the gap. The gap is what you are speaking, what I'm speaking today and doing in the OPD or OT tomorrow. If the gap is there, then it's not going to help. Last is focusing on the negative aspects. If anybody has read this book on the cumin seed, The Life's Amazing Secrets, he talks about cumin seed. Has anybody had something stuck in their teeth ever? Your tongue keeps going to that. It forgets to do everything else. You just keep, until it is gone, you will just keep on, being very uncomfortable. So mind like the tongue, default settings drifts to the negative, and therefore, whenever a patient has a negative aspect, just forget about that negative, remove that cumin seed from your brain and your tongue, and think differently. So find and destroy all these roots of bad communication. I've shared 10 of the roots so that this leaning tree of doctor-patient communication doesn't fall. And to find the roots, this beautiful tree is just showing you the roots, actually, you have to introspect. Thank you very much for this.
Thank you very much, Dr. Hello. We have 2 more speakers, so we'll have to divide the time because we're exact 20 minutes and we want to keep 5 minutes for questions.
So I'll call upon Dr. K.V. Satyamurthy, head of our cornea refractive surgery from M.M. Joshi Institute, Karnataka. So he'll be speaking on the communication problems that we face in our refractive surgery practice. It's a very fast-driven, commerce-based and very high aspirational surgery. So obviously, that's where you're going to really have problems. Over to Dr. Satyamurthy.
Good afternoon. Thank you, Dr. Krishna Prasad, for giving me this opportunity to be part of this program. I do agree with all the speakers that communication is very, very important, because for the patient, he can get the answers only from the doctor, not his neighbor or his relatives or somebody else. So it is, patient has got every right to get his doubts cleared, and he has every right to ask the doctor as to what, because he is undergoing the treatment or undergoing the surgery, whatever. And then communication refractive surgery is very, very important, because for 3 reasons. One is they're all youngsters with lot of aspirations in life, and along with that there will be a lot of doubts also. So we'll have to clarify. Second thing is the present generation, they Google a lot, they ask a lot of people, they get their doubts. So all these doubts need to be clarified. Third thing is they would have paid more money for refractive surgery, and money always equates the doubts. So the chair time. Now, patients' expectations and the fears, which are quite natural actually. First thing they ask is whether my number goes completely. Second thing, whether I'll get 100% good vision after surgery, irrespective of whether patient had very good vision before surgery with the glasses or not. Once the refractive error goes, it will never return. Whether the same number will come back to me or not, these are the fears they have. And then there is no need of wearing glasses throughout my life. Once the laser is done, or once the refractive error goes, that's what they think. And then any number can be corrected with a laser. Whether it is -1 or -20, it has to be corrected with laser. And once the error is corrected, there is no need to come back for follow-up. And there is an age limit for this. So I am about 40, 45 years old, whether I can still go for surgery or not. And LASIK is only for minus numbers. These are some of the doubts they have. And then whether it's a painful procedure, it's too expensive, it has a lot of side effects, and then one can become blind following surgery, because both eyes are done simultaneously, one after the other. So all these questions can be answered only with counseling. For this, we'll have to explain the patient about this thing, the type of procedure. This comes after evaluating the patient completely and then deciding as to what can be done for this particular patient, so that we can get rid of the refractive error. Now, one thing I liked from Madam's talk is this: you will have to be positive. So this is what the patient also expects. That is the body language probably that reflects in us. And then address each and every question of the patient. In my practice, actually, I don't talk much to the patient because the chair time is very, very important. And then I tell them that counselor has been trained very well. Still, if you have doubts, you come back to me. Then we'll sit and decide. And that can be done only after completing the evaluation test, evaluation of these things, to know whether you are suitable for this procedure or not. And we can tell the patient that laser correction takes only 5 minutes per eye. So 10 to 15 minutes, your surgery will be over. And then ICL is around 5 to 10 minutes, and then absolutely painless procedure. And then you can discuss with the patient about do's and don'ts also as to what he or she has to do after surgery, and then why follow-up is crucial. This is very, very important, because many people think that once the refractive error goes, that means the entire disease has gone. Myopia is a disease, actually. So why should he come back for follow-up? All those things we'll have to discuss with the patient. And then to expect what? Say, my vision earlier with the glasses was poor, and how can it be corrected completely and I can get back to the same vision? So what to expect? This also we'll have to discuss with the patient, so that all these things have to happen prior to surgery. Whatever we speak after surgery doesn't hold good at all. Why the patient has to come back for follow-up? We can show him the photographs, and I have only corrected the refractive error probably. So you'll have to come back for these reasons. There can be thinning in the area. It's just like a old cloth stretching, and then you can develop breaks. That can happen anytime in your lifetime. So, and then it may be, the vision may be good, very good now, but later on you are likely to develop the complications of the disease as such, the myopia. There can be myopic degeneration in the center, or this is one, I'll just give one example. One-eyed patient, after phakic implantation, got 100% vision, 6/6. Patient was happy for 2 years. Suddenly, she came back rushing, saying that my vision has dropped since yesterday. Then when I saw there was a subfoveal blood clot, that was because of myopic CNVM, which also we'll have to discuss, maybe in a subtle way prior to surgery, that this is what can happen to you. And then the post-op counseling is very, very important, because many patients, the counselor, or even we for that matter, we also tell the patient, we'll tell him that, wow, everything goes off well, and your vision will be very good. So promise him sun, moon, everything, and that is possible, but it is not so. One thing is because of dryness, which we'll have to explain, that this will be all right. And then the contrast sensitivity, which is low in the beginning, will come back to you, and then everything looks unfaded, and then your colors, everything will come back. And then, so when to expect complete correction, especially following surface ablation. It may not be complete in the beginning, but later on patients do not. And why post-op follow-up, just now I discussed. So all these things, again, we have to tell the patient, and then to talk about regression after surgery, as to, well, see, many patients, they think that your number has gone completely and it will not come back, but there's something which is beyond our control. that is say regression or under or overcorrection, which also we'll have to discuss later with the patient. What basically they want is, I mean, this is how I put it. Say a person who is without glasses, he can't go to the market, he can't go out of the house and do something. Whereas now that is not the problem, and whatever that comes, that remains is very, very small. And then you tell your optometrist to make him read bilaterally open, so that they do not, otherwise they have that habit of closing one eye and seeing with the other, and so these things. So like this communication is one thing which definitely reduces a lot of problems post-surgery, and the patient has got every right to know or to get rid of the doubts before surgery. Thank you very much for your patient listening.
Thank you, Dr. Satyamurthy. Now we have the best for the last. Dr. Deepti Joshi will be speaking on the communication skill training for the postgraduates. I think, as I told you in the beginning, there's no curriculum for good communication, but having said that, there are certain time-tested lessons for the youngsters, postgraduates, how to communicate and how not to get into trouble and how to be good at your practice. Over to you, Dr. Deepti.
Thank you, sir. At the outset, I would like to thank Krishna Prasad, sir, for this wonderful opportunity. So why communication pearls for postgraduates is important? Basically because it's not a part of curriculum in many states yet. And the major foundation between a doctor-patient relationship happens only because of the communication which happens between the doctor as well as the patient. And that is the first step how the patient actually judges it. Even if you give a bit of altered treatment, but yet if you have made the patient happy by the communication way, the patient will still come back to you for a second consultation, maybe for the same problem. But if our speech is not good, our delivery is not good with respect to our facial expressions, this patient is never going to come back even if you give the exact results to him. Communication doesn't mean just oral skills, it means the body language, the facial expression. It is a huge part of the science which is being put together. So when you come to the communication per se for the postgraduates, for the senior or the junior residents, there are 10 yes, which I would like to say. The first one is be calm and confident as in when the patient enters the room. The next point, a good greeting. A good handshake when the patient enters makes the patient feel that he is being wanted in the room. It may not be as firm as when you meet your friend or your close colleague, but then still a small amount of handshake would do a good wonder. Smile often, but look at the position of the patient or the condition of the patient before smiling. An end of patient and you keep repeatedly smiling may not suit the scenario, but then don't keep, and second point, don't keep smiling continuously, but I think a small break and then giving a small smile makes the patient being wanted in the room in which he is being present then. Address with the first or the last name of the patient. When I did my MBBS, I did it in a government medical college in Bangalore, and we used to address most of the patients as Ajja and Ajji, that is Dada, Dadi. But then when I went to a private medical college for my MS, I realized that none of them liked us addressing them as Ajja and Ajji, despite them being Dada and Dadi. So that is what makes, they did not like them to be addressed by their age. So it makes a very lasting impression when you address the patient either by their first or the last name. And the most important point would be if you add a Mr., a Miss, a suffix of Mrs. makes a very big impression, and keep explaining the same, you keep using the name, okay, Mr. So-and-so. So it really makes them feel closer to you when you take their name and address them by their name. And always sit down. When I was searching for the post, as a whole, when the communication of the doctor's part I was searching, I found this very small research where they have compared the happiness of the doctor in a scenario where patient is standing when examining or when taking a history from the patient versus a doctor is sitting when taking a history from the patient. They have noticed that in the same amount of the time when a doctor has been sitting down during the patient's examination, the patient felt that he has spent a more time in this OPD as compared to when the doctor was standing or leaning over the patient and asking him, oh, acha, kya hua? So the patient felt the doctor is in a hurry, he wants to leave, and that was an attitude which was considered as a negative with respect to that communication research journal which was published. Give an opportunity to your patient to speak.
आँख में बहुत दर्द होता है यार,
इधर रखिए,
रखिए बहुत
रखिए मैं देखती हूँ।
पेन बहुत रहता है, खुजली बहुत करने की।
हाँ रखिए, बस हुआ, पीछे जाइए। आप बाहर बैठिए, सर एक बार देख लेते हैं। हाँ? 10 मिनट बाहर बैठिए, उसके बाद सर देखते हैं।
So if speaking is silver, listening is gold. We all know that the senior resident, junior resident or the postgraduates may not be treating the patient, and finally the patient will go to the senior consultant for the management. It's basically the history and the clinical findings which they are supposed to write before passing the case on to us. But yet it's very important to inculcate this habit of listening in our postgraduates, because this is when the patient, most of the patients do come to us to just explain their feelings, to just explain themselves of their problem. It may be a minor headache, minor itching, but to just explain their problem, to be felt, to be heard, which is not happening in their home, is what is happening in our OPD most of the time. So listening gives listening makes an important skill from the communication point of view. The next point would be eye contact. Don't freakingly keep looking at the patient continuously, yet to some extent a good eye contact which is broken sometime. So you need not keep staring at him without blinking, but then every now and then looking at him makes him really feel that you are listening to what he is talking. Hand gestures makes him feel that he is being wanted in the room. Lean a bit towards him makes him feel that he is again being wanted in the room. So body language, facial expressions, hand expressions plays a very important role when we are communicating with the patients. It's not just our oral part which plays a role. Ask open-ended question. So what do we mean here? There are two types of question: closed question, open question. So a patient comes to you with a redness. Acha, aapko redness hai? And patient says, हाँ. Now what did we do? This was a closed question. But if you tell them, tell me something about your redness. Since when have you been having this? And patient says 2 sentences. These 2 sentences may hardly take 10 seconds extra of that, but these 2 sentences are going to make a positive impact for the patient in your OPD. So what, why, how, when, all of these should be inculcated in your questions. Avoid yes or no answer questions in the OPD, which become the close-ended question. Restrict medical jargons. Postgraduates, senior residents and junior residents, we understand you have just passed your exams. You know a lot more theory than even I think consultants who have been practicing in special niche OPD for all these years. Yet explaining a patient that you have got a Duane's retraction syndrome type 1 with an upshoot and downshoot makes a lot of haywire creates a lot of chaos in the patient, rather than telling कि आंख का एक नस बचपन से थोड़ा सा वीक है, जिसके वजह से आपका आंख बाहर नहीं जा रहा है, अंदर रहने के वजह से आपका सर टेढ़ा है. I think some part, maybe he wouldn't have understood 100% of what we are speaking, but at least he understood that some part of the nus is weak, and that is why my eyes are tilted out, so let me undergo a squint surgery to make the nus or the eye straighter. So using less of medical jargons becomes important. And finally, end your talk or your session as positively as possible. So we may know a 90% of glaucomatous optic atrophy may not get back much vision. आंख चला गया है, नस मर गया है. Rather than this, 90% नस वीक है, लेकिन अभी भी 10% बचा हुआ है. हम पूरा कोशिश करेंगे इसको बचाने का. So we are not promising the patient that yes, this 10% will remain throughout your life. No, but we are telling that हम कोशिश करेंगे इसको बचा के रखने का, आपकी भी help की ज़रूरत पड़ेगी. So maybe this positive point which we are ending our talk with the patient will make him have a hope कि शायद ये बचाने की कोशिश करेगी. He will come back to you for that and he may refer few more patients to you. So ending with the positive notes becomes very important. Finally, there are 10 yes, but then there are 3 no's also for all the residents who have been starting. The first point, which has already been told by ma'am.
No, not that photo on the Facebook or Instagram, please. Not that. Please crop me if you're putting that photo or edit something, do something, put some beauty face, do something. Okay, I'll get back to you in some time and I'll send you one more photo which you can put. चश्मा निकाल ली? क्या हुआ?
आंखों से पानी जा रहा है डॉक्टर को.
इधर आना एक बार. ये सब कब से हो रहा है?
10 दिन हो गए डॉक्टर.
हाँ, ठीक है. कुछ दवाइयाँ ले रहे क्या?
नहीं, कुछ नहीं डॉक्टर.
Hello? Yeah, I've sent the photo which you should upload. Please upload that photo, not this one.
The patient's face explains it all.
And do some nice editing work, please. 1 minute, I'll get back to you.
So, a digital era, we all are hooked to our mobiles, we are hooked to our laptops. So many times there are certain conditions, we do Google it up before we reach the diagnosis of the patient. And nowadays in the current era where you can just click it and search what is this condition, this has been applied so many times in the OPD. But it would be better not to use your mobiles or laptops or computers in front of the patients as much as possible. Even if there is an urgent necessity to use it, we may excuse ourselves from the patient, walk out for a few times, or maybe do some procedure on the patient, make him wait for some time, and then you can Google out the diagnosis, put together, and then come to the treatment part of it. But avoid digital usage as much as possible in front of the patient. The next one would be to avoid slang words.
यार वो shit drop हो गया अपेक्षा अपेक्षा ये drop हो गया यार
क्या न्यूक्लियस में
हाँ क्या करूँ अभी क्या करना है
बोला था ना तुझे छोटा रेक्सिस नहीं करने को हो गया ना अभी कॉम्प्लिकेशन अभी क्या करेंगे रुक मैं वॉशरूम के आती हूँ फिर देख ओके
Agreed, the eyes are closed, but then the patient's ears are wide open. And he has heard all the words which are responsible for his panic. Shit, drop ho gaya, bola tha nahi karne ko. So even if you make perfectly fine, even if the retina consultant removes out the nucleus, even if you place a perfect sulcus IOL and the patient ends back getting a 6966, but the patient will know that we have done something wrong inside the OT. So do as much the communication is important in the OPD. Communication is very important in the OT also, where the patient's other senses are more active because the eyes are being covered up. So mind what you speak, a hand gestures, not panicking, not using certain words, not using slang language becomes very important. And the last and the final one, never trivialize any problem. A minor headache which had been referred from many places reached us, and finally just because the patient told me, 5 doctor ke paas jaake aaye hai, kuch alag karo. And I did an MRI in the child and it turned out to be something grave, intracranial tumor. So it could be a small thing for us, but it is a major thing for the patient. So never trivialize any problem. A small redness could be a heralding sign of something underlying thing. So take care of each and every problem of the patient when he presents to you. So with this, I would like to say that this is a small quote, but it plays a very important role in our communication journey. People will forget what you said, people will forget what you did, but people will never forget how you made them feel. And I think we make them feel better in all the way, maybe our hand gestures, our facial gestures, body language, ocular signs, as well as our clinical skill. So clinical skill comes in the end, and all of these comes way before that, before we start examining the patient. So with this, a happy communication to all of you, and thank you, KP sir, once again for this wonderful opportunity. Thank you.
I know that all of you will have stories and a lot of anecdotes and a lot of messages in the same communication. You all have been practicing. You all have been successful practitioners. You always have, just like we shared things, you have lots to share, but only thing is we need to put our best practices. I think there'll be probably a platform in future where we all can probably put the way we explain things, how we give our prognosis, how we settle some of the patient queries. Because the way I do, maybe you may have a better way of doing it. So I should actually learn from you and vice versa. So I think, with this IC on communication, we hope that this small effort will help at least the beginners to find solution to some of their nagging problems, and will have a much happier patient. We do our best, we know clinically, but communication is something that can add more value, can embellish the whole efforts into a much fruitful one and keep our patients satisfied and happy. Thank you very much for a patient hearing. Thank you very much, Dr. Arun sir, also for moderating this session. Thank you. All the instructors, please come up for documentation. Yeah.
Speakers, please come up for the group photo.